Hi, this is Nurse Inga, and you're watching Vascular Disorders. Let's begin our review with a discussion about blood vessels. Arteries carry blood away from the heart to vital organs and tissues. Their main role is perfusion and the delivery of oxygen and nutrients. Skin that is well perfused has a normal color, warm temperature, good pulses, brisk cap refill, normal hair growth, and appears healthy. Organs that are well perfused function normally, so you should see normal mental status and good urine output. Veins are responsible for returning blood back to the heart and the circulatory system, and this removes waste products in combination with the lymph system. At any point in time, about 30% of our blood volume is found in the arterial side, about 65% in the venous side, and only about 5% in the capillary beds, exchanging those nutrients and waste with the cells. When you look at the difference between an artery and a vein structurally, you'll notice that the kind of middle wall there, the very muscular and also elastic layer, is much thicker in an artery than it is in a vein. The artery is more capable of constricting and decreasing flow, shunting blood back to the core, and the vein is more capable of dilating and increasing container size and decreasing preload. So arteries are more capable of increasing peripheral vascular resistance and afterload, and veins are more capable of decreasing the preload and increasing the overall vascular capacity. Veins also contain these valves in them to help move blood flow back towards the heart instead of allowing it to pool dependently with gravity. We're going to take a look first at kind of arterial diseases, and then we'll talk a little bit about venous diseases as well. So arterial vascular disease has kind of this umbrella diagnosis of arteriosclerosis, which is the hardening of the arterial wall, and this can occur from a variety of sources. But basically that middle layer, that elastic muscular layer, loses its elasticity, it becomes hardened or thickened, and it loses the ability to dilate to increase blood flow, but also to constrict to compensate for needing to increase the peripheral vascular resistance to increase blood pressure. Atherosclerosis is a form of arteriosclerosis, and this is what happens when cholesterols or plaques form on the inside of the arterial wall. And the mechanism for that is essentially there's an endothelial injury. And so let's say that we have some turbulence or some injury that occurs here on the wall of the vessel itself, and the body responds by placing these fatty streaks or plaques on top of it. And then there's oxidative stress occurring within the body that kind of hardens those plaques. And over time, the plaque grows and the lining of the artery becomes even more damaged due to these plaques. And, through the process of turbulence and the attempts to constrict and dilate, the plaque can then rupture here and it can break free. And the body recognizes this as the same as an endothelial injury, where now it starts that kind of clotting cascade where we have activation of fibrin and platelets, and we can either have an embolus that floats off into the bloodstream and or a thrombus that either limits or completely obstructs blood flow in that vessel. So if I have arteriosclerosis, I have a decreased ability to compensate for my fluctuation in needs of perfusion. And arteriosclerosis happens with age. If I have atherosclerosis, I definitely have arteriosclerosis because it's a kind of arteriosclerosis, but not everybody who has arteriosclerosis will definitely have atherosclerosis. So atherosclerosis being the formation of plaques within the vessels themselves. You've probably heard about this before if you've heard any literature or teaching from the American Heart Association and the American Stroke Association, but these are the things that cause atherosclerotic cardiovascular disease, cerebral vascular disease, peripheral vascular disease. So any imbalance in your cholesterol levels, a low good cholesterol, a high bad cholesterol, hypertension, family history, diabetes, obesity, sedentary lifestyle, smoking, elevated stress, ethnically, patients with African or Hispanic descent have a higher risk, and then older adults. Smoking has kind of this triple whammy where it causes vasoconstriction as well as hypertension, and then endothelial cell kind of irritation, disruption, and platelet dysfunction, and increasing the cholesterol. Smoking is kind of like the absolute worst thing that you could possibly do, and true of most nicotine-containing products as well, in terms of trying to lower your cholesterol. Smoking really elevates the cholesterol and the atherosclerotic disease process. It accelerates it. Our goals then when dealing with a patient who has atherosclerosis is to control the blood pressure, control the glucose, and to work with them on smoking. Let's talk then about blood pressure for a second, because these two things really go hand in hand. Hypertension leads to the development and advancement of atherosclerotic disease, and at the same time, atherosclerosis can increase blood pressure or the work that the left side of the heart has to do. So it's kind of a catch-22. Your blood pressure is controlled by your cardiac output and your peripheral vascular resistance. Your cardiac output is determined by your heart rate and your stroke volume, or the amount that the left ventricle ejects with every contraction. So hypertension is an increase then in either cardiac output or peripheral vascular resistance. So anytime you increase your stroke volume, your heart rate, or your peripheral vascular resistance, you will increase your blood pressure. In our younger populations, typically hypertension occurs as a result of an increase in cardiac output. In our older populations, it's usually a result of an increase in peripheral vascular resistance or atherosclerosis and vascular disease. A normal blood pressure is roughly 120 systolic over 80 diastolic, or less of both of those numbers. But we worry mostly about the diastolic number. And as you look at these stages, pre-hypertension, stage 1 and stage 2 hypertension, what you'll notice is with each of them, the diastolic has a much narrower range, only going up by 10 points each time, or 9, so 80 to 89, 90 to 99, and then anything over 100, while the systolic has a much wider range, increasing by 20 points at a time. And the reason for this is that you spend like 1/3 of your cardiac cycle in systole, or your systolic pressure, and 2/3 of your cardiac cycle in diastole, which is kind of your rest pressure. So systole is the pressure exerted during work. How much pressure do I have to use to kind of eject the blood from the left ventricle, and then versus diastole is kind of the rest pressure. And that's definitely oversimplifying it greatly, but to give you an idea, we're more concerned about the pressure at rest because that's kind of the overall always exerting pressure against the walls of the vessel pressure. Primary hypertension or essential hypertension exists when there's no other underlying disease process that really is causing it, but it is definitely related to other disease processes, and there are risk factors for it. So again, if you have a family history, if you smoke, if you're obese, if you have diabetes, if you have salt sensitivity, because water tends to follow salt, so that leads to an increase in circulating volume, which leads to an increase in cardiac output. And then if you have chronic activation of the RAS system or renin elevation, that will also increase not only your PVR, but also your cardiac output. Secondary hypertension exists when your blood pressure is elevated due to other disease processes, like underlying kidney disease, which would lead to that chronic increased renin or salt retention, obesity, alcoholism, Cushing's disease, hyperthyroidism, and stimulant use. So again, any other primary disease process that increases your stroke volume, heart rate, or your peripheral vascular resistance would then lead to an elevation in your blood pressure. We also have to be aware of something called malignant hypertension. And malignant hypertension occurs when the systolic has exceeded 200 and the diastolic exceeded 150. And this can cause heart failure, acute kidney injury, and even stroke. And oftentimes these patients will present with things like headache, blurred vision, may even feel kind of short of breath, but they may not really know exactly what is going on. And that's one of the most difficult things about hypertension is unless people are having their blood pressure checked regularly, they may not even be aware that their blood pressure elevated. So the underlying causes or things that can cause high blood pressure, again, increased sodium intake because water follows salt, activation of the RAS system, aldosterone, which is part of that RAS system, or just aldosterone on its own because it signals the kidneys to hang on to salt and therefore water, and increases the circulating volume. And then activation of the sympathetic nervous system, so alpha activation causes peripheral vascular resistance to increase, and beta 1 activation causes an increase in cardiac output. So all of those things can increase your blood pressure. We aim to address this first by lifestyle changes, habit modification, dietary modification, but if we need to use medications, we'll try things like diuretics. So diuretics would reduce the circulating blood volume, which would reduce preload, which would reduce stroke volume, and it would reduce our blood pressure. Drugs like calcium channel blockers and beta blockers can reduce the heart rate as well as the force of contraction, and calcium channel blockers have some peripheral vascular resistance decreasing as well. ACE inhibitors block the conversion of angiotensin 1 to angiotensin 2, so that stops the kind of triggering of the sympathetic activation as well as the release of aldosterone. And angiotensin receptor blockers are used as a second-line type of drug for people who can't tolerate ACE inhibitors. We do have some combined alpha beta blockers like carvedilol that also act similar to a calcium channel blocker, where they decrease the force of the contraction as well as decreasing peripheral vascular resistance. But they tend not to be selective beta blockers, so they do run that risk of having some bronchoconstriction. Vasodilators are possible as well, things like hydralazine, and then central agonists like clonidine that work to decrease the sympathetic activity that maintains blood pressure. So there's a lot of different things that we can do, but our first line drugs tend to be things like diuretics, vasodilators, ACE inhibitors, calcium channel blockers, beta blockers. Those tend to work fairly well with the fewest complications. So as I mentioned, hypertension is kind of the silent killer. So while the person feels fine, there are kind of irreparable injuries occurring within the body. The brain, the heart, and the kidneys can be injured without obvious symptoms. And sometimes, one of the first things people will notice is like some visual changes or just some kind of general things. Or if the kidneys have been damaged, they may start to notice some foam in the urine from leaking protein into the urine. It can lead to cardiovascular disease, heart failure, strokes, aneurysms, aortic dissections, and even a hypertensive crisis. Pediatric patients can also develop hypertension, and the young oftentimes can't really verbalize to you what is wrong, so they may just wake up screaming in pain, and that might be mistaken for night terror. They may pull on their hair or bang their head against the wall, like a child who has an ear infection that's always rubbing their ear or pulling on their ear or shaking their head. When you see a child doing something strange with a body part, oftentimes that means that it hurts and they can't figure out what to do with it. And then they just might appear irritable and tense overall because that they feel stressed, but they can't figure out why. In our pediatric populations, it's more likely that they're going to have a secondary hypertension because most young kids don't have cardiovascular disease, at least until adolescence, when they've had time to develop diabetes and obesity and salt intolerance. So these secondary diseases are usually like kidney disease, congenital heart disease, a coarctation of the aorta, which makes it harder for the left ventricle to pump, and then endocrine disorders like thyroid problems and medications that they're on. Once they reach adolescence, they have the same risk factors for primary hypertension as adults. So essential hypertension or primary hypertension in kids is usually only mildly elevated. We don't usually see hypertensive crises. So we treat with diet modification, salt restriction, exercise, stress reduction. And remember that the education can't just happen for the child. It also needs to happen for the adults or the care providers because most kids, especially, if we're seeing this in kids that are like 8, 9, or 10 years old, they're not grocery shopping for themselves. They're not, setting time limits on their, devices for themselves. So we need to include the parents in the plan of care. When medication is necessary, it's really the same as what we see for adults: diuretics, beta blockers, calcium channel blockers, ACE inhibitors. And if those don't work, we can try the angiotensin receptor blockers. Moving out into the periphery, when peripheral arterial disease becomes kind of chronic, it leads to poor perfusion of the extremities. So this is a chronic problem related to atherosclerosis. One of the things or two things I should say, that we should watch for would be if the amount of activity required to cause pain in the foot decreases, then the disease has progressed. And as the disease is progressing, we'll notice also that people will start to complain that leg pain often wakes them up at night. So these are two really key indicators that their peripheral arterial disease is becoming more severe. There are 4 recognized stages to the progression of chronic peripheral arterial disease. In the first one, they are asymptomatic, but with a stethoscope you may be able to hear a bruit and there may be an aneurysm present. Pedal pulses will be decreased or absent due to the disease. In stage 2, they'll start to have some symptoms, and this is called claudication or intermittent claudication, meaning that with activity they will start to have muscle pain or cramping and burning, and that usually is relieved with rest and then reproducible again with activity. So it's important to say how much activity can you actually do before you start to experience pain, because as that amount decreases, the disease is worsening. In stage 3, they start to develop rest pain, so it'll wake them up at night. So that's a clear indication that we've moved from stage 2, which is the intermittent claudication, to stage 3, which is the rest pain. It's usually in the distal portion of the extremities, the toes, the arch, the forefoot, and the heel, rarely the calf or the ankle. And it's relieved by placing the extremity in a dependent position, because this is a problem with perfusion. So to enhance perfusion, you want to put the extremity in a dependent position. If I wanted to enhance venous return, I would elevate the feet, but this is not the right person to elevate the feet in, because you will actually decrease perfusion. In stage 4, we have a significant ulceration of the tissue due to markedly decreased perfusion, and the skin starts to ulcerate even with the slightest amount of pressure. There's blackened tissue that it can occur on the toes, the forefoot, the heel, and because there's not adequate nutrient and oxygen delivery, these wound beds oftentimes do not heal, and gangrene may occur. The ulcer bed itself is pale, very dry, very deep, and very little granulation tissue. The foot is cool or cold. There's hair loss on the extremity. When the foot is down, it turns red, and again, when you elevate it, it turns very pale and oftentimes is very painful. It's important to keep the extremity warm, to keep it dependent, and to prevent trauma. So these patients should not be walking without shoes on, because if they step on something or hurt their foot, the wound will not heal. So daily foot checks, just like your patient who has diabetes, is important as well as seeing like a podiatrist. And the treatment for this really is like surgical revascularization, so to go in there and to bypass or to fix the obstruction. To compare that to a venous disease, the lower extremities in the venous patient who has like a chronic venous insufficiency, those are usually like a brown pigmentation from hemosiderosis, which is like a pooling of the iron deposits from the blood cells that have ruptured there. The ulcer beds tend to be very pink, more superficial, kind of uneven edges, and very wet. Granulation tissue is present, and infection is more common in these because of all of the lymphatic and venous fluid, that interstitial fluid that's not getting filtered or returned to the kidneys or the liver for filtration. So it kind of pools in the extremities, and infection and dependent edema is very common in a venous ulcer. Scarring on the legs also is common, as well as kind of venous stasis, changes in the legs. So for these guys, we do kind of compression or Uniboot or dressings, elevation, and again, a lot of education on management of their venous disease. So for going back to arterial, when we are assessing the patient with the arterial vascular disease, again, applying our nursing process, the first thing we're going to do is we're going to look at them and we're going to notice that they have those hairless legs, poor, no pulses, rubor when dependent, pallor with elevation, painful deep necrotic ulcers on the toes or the ends of the feet, pale dry wound beds, really not healing. So we're going to note that, hey, these guys have ineffective peripheral tissue perfusion. They're at risk for impaired skin integrity, so we really have to protect them from future injuries, and oftentimes they have chronic pain. So our plan for them is going to be position them with legs dependent, and if you are delegating positioning or anything to somebody else, this is important because they may not understand this. These should not be people who are, propped up with the feet elevated in bed. Even when sleeping, we should work out a way for their legs to be dependent. The feet need to be inspected by them daily, by us every shift. Educate on the risks, claudication, no bare feet, because those injuries don't heal, and then educate on their prescribed meds. So they'll be on things like, lipid-lowering meds, blood pressure meds, and then a med called Trental, and Trental's a pretty cool med because it increases the flexibility of our red blood cells to travel through those kind of tightened or narrowed spaces. So instead of clumping and occluding, they can actually get through and provide some enhanced oxygenation and perfusion. The thing that we're really monitoring for when we go in and we're doing our distal CSMTs, right? So color, sensation, mobility, and temperature is kind of the worst case scenario. So when you're thinking about what is it that I'm looking for, well, that right leg on the screen is what you're looking for. So you're looking for the 6 P's of ischemia or acute arterial occlusion. So the first thing is pain. It's very painful to not have blood flow. Pallor. So if we say that with blood flow you have normal color, without it the extremity becomes pale. Without blood flow, you also don't have a pulse, so pulselessness, and then you get numbness and tingling, so paresthesias. As the muscles no longer have oxygen and glucose to do the work, they can't work, so you get paralysis. And then without perfusion, you also don't get the warmth of the blood flow, and so you get what's called poikilothermia, or kind of assuming room temperature, so you get a cooling of the extremity to the surrounding temperature. The next P would be phone the physician, because there's nothing that you can do as a nurse that will improve the outcome of this patient. It's an acute surgical emergency. Atherosclerosis causes surgical emergencies in other parts of the body as well, such as the carotid arteries. This is a picture of an endarterectomy. So carotid artery disease, remember you can palpate a thrill, but you auscultate the carotid arteries while the patient's holding their breath to listen to a bruit. A mild carotid artery stenosis would be less than 50% occlusion, moderate 50 to 69, and severe 70 to 99%. Again, it's fixed with what's called a carotid endarterectomy. After surgery, you would monitor the surgical site for bleeding, and because it's right next to the trachea, watch for things like hoarseness, stridor, tracheal deviation, any signs of a hematoma, and then also neurologically, any signs or evidence of a stroke or difficulty with cerebral perfusion. For our aortic arterial disease, so like our aneurysms, these can occur at any point on any artery, but because the pressure in the abdomen and the thorax are so high in the aorta itself, those tend to be the most common sites. So an aneurysm is just a weakening in that middle layer or that muscle wall of the artery that leads to kind of this ballooning of a portion of the artery, and obviously the risk is that it's going to rupture. So the risk factors for aneurysms are the same, obviously, as peripheral arterial disease, because it's the hypertension and the damage to the vessel that causes this. In addition, things like genetics, Marfan, syphilis, having a bicuspid aortic valve, so already having like a congenital defect, and then Kawasaki's disease all increase your risk factor for developing an aneurysm. These are diagnosed by CAT scan with contrast dye, and whether or not they're repaired or followed depends on the location and the size. The goal is to control hypertension to avoid rupture. If the aorta itself is dissecting, which is different than an aneurysm. So a dissection is when there is a sudden tear in the layers of the intima. So there's blood can get into the layers of the 3 layers of the vessel itself. It creates what we call a false lumen, and it starts ripping the layers of the vessel wall apart and almost creating like this sac off to the side. It grows rapidly under pressure, and we start to lose distal circulation. This causes severe tearing and ripping pain wherever it's located, and if it ruptures, the person will rapidly bleed to death. So you can see here that the fix for this is like Dacron grafting or surgical repair. They also go inside and they can stent it from the inside, where they kind of blow up like a stent on the inside that kind of blocks blood from entering the dissected area. Once surgical repair has occurred, the nurse needs to be incredibly diligent about checking color, sensation, mobility, temperature, and pulses distal to the surgical site, per the physician orders, but typically, frequently for the first 24 hours, and then, it becomes less frequently, and then every 4 hours, and then every shift. But really what you're looking for is signs of that acute arterial occlusion, because the risk of occlusion, even with stenting, but also with bypass surgery, is the highest in the first 2 weeks. So this is a picture of a femoral distal bypass and a femoral popliteal bypass, or a fempop bypass, where they harvest a vessel either from a different part of an extremity or from like a donor, and they bypass the obstruction, or repairing the aneurysm, and then we're assessing the perfusion distal to the site. So just keep in mind that peripheral venous disease, we kind of looked at very quickly, is the accumulation of fluid and waste, versus peripheral arterial disease is the inability to provide perfusion, so oxygen and nutrients. With peripheral venous disease, there are a couple things that we worry about. So superficial thrombophlebitis, which you are probably familiar with in terms of like assessing an IV site, but it would be localized warmth, tenderness, the sensation of a cord along the vessel itself. You might see some redness, swelling, and hardness. A venothromboembolism is the same thing as a DVT, and this is a clot in the vessel or vein due to endothelial injury, venous stasis, or hypercoagulability. This is referred to as Virchow's triad. So these are kind of the three things that exist that increase the risk of a VTE or DVT. Swelling is present distal to the clot because remember that, on the venous side, blood is returning to the heart, so it blocks the flow of that interstitial fluid back to the heart. So if I had a clot in the middle of my thigh, I would have swelling from my foot to my thigh. If I had a clot in my calf, I would have swelling from my foot to my calf. So the swelling is always distal to the clot. Look for the risk factors, implement prevention measures, and watch for signs and symptoms. Tests that could help us determine the risk or the existence of a DVT or VTE would be a D-dimer, which is elevated in the presence of clots within the body. So it's not specific for DVT or VTE, but it would be elevated with one. We want to look at the PT-INR and the PTT or APTT to determine our current clotting levels. So PT-INR is used for oral anticoagulation and APTT is used for heparin or injected anticoagulants. We're going to look at the H&H to see if there's any evidence of bleeding or to see if we are like hemoconcentrated and have an elevated H&H. And then we want to look at ultrasound, so venous compression ultrasound very specifically to see if there's any evidence of clots within the leg. If we do suspect a DVT or VTE, a CT angiogram of the chest, so looking very specifically for blood clots within the pulmonary vasculature is essential because the reason we're worried about a DVT or VTE is not because there's a clot in a vein in the leg. If that's all that happened, we would give people anticoagulants and go on our way. The problem is that they break off and then they travel up through the inferior vena cava into the right atrium, the right ventricle, out through the pulmonary artery, and then they get wedged in the pulmonary vasculature and they cause a lack of blood flow past the alveoli and hypoxia. So pulmonary emboli are incredibly dangerous, and if they're large enough, they can actually be fatal. So the reason that we worry about DVTs is because of the end result of the PE. So CAT scan angiogram is the kind of the diagnosis gold standard for PE assessment. Venous insufficiency causes that stasis dermatitis or that kind of brown legs, as well as, like kind of the thick scaling, dry skin, or weepy skin, depending on how much edema they have, stasis ulcers as well. And then varicose veins, venous valvular insufficiency from chronic back pressure. So we talked about the valves within the vessels themselves, and patients who have prolonged standing obesity, pregnancy, are at greater risk for varicose veins. And basically it's just increased back pressure against those valves causes them to leak, which then causes the vessel to dilate and become very tortuous or kind of like bulging and twisting, and those can become actually very painful for people, they sometimes actually have to surgically fix them because they're so painful. So that is just a quick overview, mostly on arterial disease, but thank you for watching.